So good morning, everyone. This is Makis Avgerinos. He's a well-known vascular surgeon and specialist in pulmonary embolism and the management of pulmonary emboli. So Makis is going to talk to us today on the diagnosis and management of pulmonary emboli.
Thank you, Dr. Papas. It's always a pleasure to be with you. I really enjoy participating in your grand rounds and discussing on pulmonary embolism and sharing my experience on the US and the European side. I was just trying to I was a little delayed because I was trying to incorporate a new slide in my talk. In case you haven't noticed, I mean, it was, I think last month, it was published in the Journal of Vascular Intervention and Radiology, a paper indicating the trends in pulmonary embolism thrombectomy over the past 5 or 6 years. Can you imagine that the PE intervention rates have increased in US by 700%? 700% increase in pulmonary embolism intervention. So there is something going on. Maybe it's industry pushing. I think we are definitely helping patients we could not help in the past. Maybe some people are overdoing it, but it's definitely there that PE intervention can change the outcomes of these patients. So let's take it from the beginning.
So Makis, we don't see your slides.
Do you see them now?
No, we just see a screen that says Zoom.
Okay, let me try to share again.
Yeah.
How about now?
Yeah, there you go. Yeah, if you can just put it on screenplay, the bottom down here on the right.
Yeah, it should be full screen, right?
We see your slides on the left. We don't. There you go. Perfect. All right. Thank you.
Okay. If there is a lag, let me know. I will change to my other computer. I'm running from my laptop now. Okay.
No, you're
Good.
good. You're good. Go ahead.
So you're going to be seeing more and more DVTs and PEs. The rates are increasing because we have an aging population and we have a better diagnosis compared to what we had in the past. We need to understand that PE is the most common preventable cause of in-hospital death. 10% of these patients will die within 3 months. 50% will have post-PE syndrome. That's some kind of exercise limitation at 1 year. Over the past 10 years, we have seen a very slight decrease in high-risk PE mortality rates from 48% down to 39%. But looking at all PE mortality, it really hasn't changed much over the past 10 years. Starting from the basics, diagnosis, it always starts with clinical suspicion, chest pain, back pain, syncope, shortness of breath. Lab tests, D-dimers, arterial blood gases, BNP and troponin, ECG, pulse oximetry, and of course, imaging. When it comes to imaging, you need your CT pulmonary arteriogram. Not only you can see the clots in the pulmonary arteries, you can also see the dilatation of the right ventricle against the left ventricle. Echocardiogram and invasive arteriogram when you're planning for an intervention. Scintigraphy, I've only seen probably once or twice over the past 10 years. I don't think it's used that much anymore, the perfusion scan. And looking at the diagnostic algorithm, when at the emergency room you're suspecting APE, it really depends on if the patient is stable or not. If the patient is stable, you can do your clinical probability, then order D-dimers or CT scan depending on if the probability is low or high. If the patient is unstable and you're suspecting that this is a PE, you can do a quick scan echocardiogram on the table and then rush to systemic thrombolysis depending on the findings. Regarding clinical probability for the residents, we do have the Wells score. Wells score less than 4, probability is low. Wells score more than 4, probability is high. And what the Wells score for P looks at, Clinical signs and symptoms of DVT: P likely or unlikely, heart rate more than 100, immobilization for at least days, previously objectively diagnosed DVT or PE, hemoptysis or malignancy. Now, to better communicate, we really need to know how we classify PE. Not all PEs are the same. Low risk or non-massive PE is when you have no right ventricular dysfunction. When you have some kind of right ventricular dysfunction, either seen in the echocardiogram or through the biomarkers, positive troponin and BNP, then you have an intermediate risk PE. This is the submassive PE. Now, be aware that when you are seeing a PE, you should always order troponin and BNP. Otherwise, you cannot really classify it. When on top you have hypotension, and of course you have right ventricular dysfunction, this is the massive pulmonary embolism. This is the high risk PE. Anticoagulation is the standard of care for everyone, but as the severity increases, the chances of having a mortality event increase, so you need to escalate treatment. And escalating treatment in PEs, systemic thrombolysis, catheter thrombolysis, aspiration thrombectomy, surgical thrombectomy, filters, and ECMO. Of course, there is a treatment gap here. It's a difficult decision, controversial and weak evidence, high expertise required, and high risks involved in the operating room. Not everyone is willing or happy to take a pulmonary embolism patient who is dying. But then you question what happens if we leave all this clot behind. This is the death spiral. This is the pathophysiology of pulmonary embolism, how progressively the heart is stressed, and eventually it cannot be pulsatile anymore till it gets to an arrest. The contractility decreases, and you get an obstructive shock that leads to death. And we do have meta-analysis indicating that 18% of the patients who go through a PE will have ongoing right ventricular dysfunction. 11% we have New York Heart Association functional impairment 3 or 4, and the readmission rate at 30 days is 24%. So it makes sense to rapidly unload the right ventricle to prevent all these events. And this is what happens if clot stays behind. This is the pulmonary hypertension. Or even if you don't develop CTIF, you can develop long-term PE syndrome. Roughly 50% of these patients will develop some kind of exercise limitation in the long term. So why it matters intervening early, reduce mortality, and prevent long-term complications. Let's look at the data. Systemic thrombolysis against anticoagulation is associated with a 47% mortality risk reduction, but this comes at a cost. Major bleeding rates, 9%, 1.5% bleeding stroke. And don't forget that the majority of these patients have a pulmonary embolism because of recent trauma or because of recent surgery. So they are contraindicated for systemic thrombolysis. 2014, the first randomized trial got published. The ECOS catheter, that was the ultimate trial. They showed that by doing catheter-directed thrombolysis, you can reverse RV dysfunction within 24 hours, much faster than it can be reversed with heparin alone. In simple words, you can get the benefits of systemic thrombolysis without the associated risks. And since then, we've seen a tremendous increase in catheter interventions for pulmonary embolism. Multiple devices, multiple lytic catheters, multiple thrombectomy catheters, trials, and so on going on. And we are getting better. We are removing more and more thrombus. We can do it faster. We can do it with fewer complications. But there is an elephant in the room. Everybody's doing a trial indicating that the device worked fine. But if there is no control arm and the control arm is anticoagulation, you cannot really say that the device works fine. Works fine against what? So we need a randomized trial because right now we are putting the horse back in front of the cart. And the randomized trial that we are all waiting is now running. It's the P-track trial, Makis being the principal investigator. They're looking at functional outcomes, randomizing patients between anticoagulation or PE intervention for intermediate risk PEs. It's in the guidelines. The European Society of Cardiology and the actually newer guidelines indicated that catheter interventions can be considered as an alternative when systemic thrombolysis has failed or when systemic thrombolysis is contraindicated. When systemic thrombolysis has failed, or when the patient is not improving, we consider failure if within 2 to 4 hours of systemic thrombolysis, you don't see an improvement in the heart rate or in the hemodynamics. Right now, we do have guidelines in Europe coming both from the European Society of Cardiology and the German Society of Cardiology, indicating that if you have contraindication for systemic thrombolysis, you need to consider a catheter intervention, most likely being mechanical thrombectomy. For the submassive pulmonary embolism, if the patient is deteriorating or the vitals are not improving, this is when you pull the trigger for either systemic thrombolysis or mechanical thrombectomy. This is the algorithm that we have been using at UPMC. It really depends on the classification of pulmonary embolism. If it's a low risk or intermediate low risk PE, anticoagulation is enough. If it's intermediate high risk pulmonary embolism, meaning you have positive troponin and BNP, you have positive echocardiogram, then you need to consider intervention. It can either be catheter thrombolysis if you have no bleeding risk, or aspiration thrombectomy. Now, not all patients with intermediate high risk PE necessarily need to undergo an intervention. You can wait, you can observe them overnight and see if they're improving. If systolic blood pressure is very soft, maybe you have to intervene. If heart rate is more than 120, maybe you have to intervene. If the patient has very low oxygen, inability to move and talk, then maybe you have to intervene because the patient is probably ready to decompensate. Now, for the high risk PE, you really don't have time to react. Systemic thrombolysis may be best, but if it is contraindicated, then you have to go for aspiration thrombectomy. And then why not do aspiration thrombectomy for everyone? The devices that we have been using for the past 10 years or 10 years ago were mainly thrombolysis or the ultrasound-assisted thrombolysis. We were still giving high volume of lytics. The patients required to stay in the ICU for days, and the logistics were complex. And the aspiration devices we had were actually low, small bore devices, meaning ineffective aspiration, and we had a lot of blood loss. So the landscape has changed. We now have contemporary devices, both on the lytic side and on the mechanical thrombectomy side, that can actually be a lot more effective. Bottom line, thrombolytic and non-thrombolytic techniques are complementary. This is where we intervene. You can access the IJ, you can access the common femoral vein, navigate your pigtail through the heart into the pulmonary arteries, and then you can either do thrombolysis using any of the available catheters. These are generally smaller devices, and don't forget that the lytics can circulate into the distal branches and break down the clot there where no thrombectomy device can go. But still, the procedure is prolonged. The patient has to stay in the ICU, the logistics are complex, and you can still see bleeding events. Regarding ultrasound-assisted thrombolysis, there was a lot of enthusiasm in the beginning. Maybe there's still some enthusiasm, but the story that ultrasound can speed up fibrin lysis may not be justified. I was principal investigator of the Sunset PE trial. We compared PE thrombolysis with and without ultrasound assistance, and there was really no difference in thrombus reduction within 48 hours. So if you really want to save money, maybe it's not worth using ultrasound-assisted thrombolysis. Just use a plain multi-site Holt catheter. Of course, we now wait the results of the HI-PEITHO trial, randomized trial comparing anticoagulation against ultrasound-assisted thrombolysis. A new catheter on the block, the Basquiat catheter, multiple wires, dripping TPA. You also have a mechanical effect. They're trying to create on-table protocols. It looks promising, still waits to be seen. The comparison of the available studies indicates that with the Basquiat catheter, you can actually manage to get more thrombus out within 48 hours compared to any other thrombolytic device. Moving on to the mechanical thrombectomy, minimal bleeding risk, no contraindications, quick reperfusion, but they're expensive, they're larger, they may be difficult to navigate with injury risk. The penumbra device, we started with the CAT 8, we moved to the CAT 12, now we have the CAT 16 available. The lightning flush that is actually very, very effective. Um, this is a case I did a few years ago, the CAT 8 device. Look at the left lung. You cannot actually see it at all because of the thrombus. After aspiration, you can see I'm coming from the IJ. Look how nicely the left pulmonary artery has opened up. Storm P trial, randomized trial, was just finished and actually very recently published. They showed that using mechanical thrombectomy with a penumbra device, they achieved a significant reduction of RV dilatation compared to the heparin alone. And even the functional outcomes, the 6-minute walk distance at 3 months, were significantly better for the mechanical thrombectomy against anticoagulation alone. Flow Triever device may be the leader of the market right now. Very smart design, percutaneous access to the common femoral vein, very large device, 24 French. You typically only need to aspirate, but if the clot doesn't come out, you can use the Flow Triever discs. Let's look at this 42-year-old male who had systemic thrombolysis, but it really didn't work. The patient decompensated 2 days later, and now he has a heart rate of 140, starting at 85%. I'm accessing through the groin, getting the pigtail into the heart, confirming I'm in the right spot, placing a 24 French sheath, and through the sheath, I'm advancing the Flow Triever device. Look how smooth it goes through the heart into the left lung. And once I'm in position, now I'm going to initiate aspiration. And then I cannulate the right side and again perform aspiration. You also have the ability to introduce a smaller catheter that will get you deeper in the branches and remove more distal clot. This is what we removed. Patient did well. Next day out of the ICU. Peerless trial. They compared Flow Triever against catheter-directed thrombolysis. While there was no difference in mortality, there was a difference in the ICU stay. This is another study on the high-risk P patients. Flow Triever has actually run the majority of trials right now available, and evidence comes from the Flow Triever trials. It seems that even in high-risk patients, but take it with a grain of salt, it seems that Flow Triever can offer more than systemic thrombolysis or definitely anticoagulation alone. The Persevere study, Flow Triever arm, that's a randomized trial against standard of care It's actively enrolling. The Peerless 2 study, flow trigger against anticoagulation, actively enrolling. Moving on to the AngioVac device. We used AngioVac in the past. It was very rigid. The device evolved, and now we have the AlphaVac device. You don't need extracorporeal circulation. You do have a handle, and you aspirate manually. This is the AngioVac of the past. We could remove efficiently large amounts of clot, but we did have complications because of the rigid nature of the catheter. But let's look what we have today, the AlphaVac device. You see this 53-year-old patient with bilateral pulmonary emboli. I'm introducing the pigtail. You can see how I'm spinning the pigtail. You really need to go through the tricuspid valve and not behind the tricuspid valve. That's why you want to use a balloon catheter or a pigtail. Once in place, you exchange with a stiff wire, introduce a 24 French dry seal catheter sheath, and through that, you introduce the sheath of the AlphaVac catheter. So the sheath will now be positioned into the main pulmonary artery, and you remove wire and dilator. And at this point, I'm going to introduce the AlphaVac catheter that opens up a funnel. Look at the funnel as it opens up as I come out of the catheter. This is a 33 French funnel. You can understand how powerful it is to remove the clot. And look how nicely you can twist it to the right side without the need for wire and recannulation. And I can then advance it into the right pulmonary artery. And at this point, I'm aspirating. You can look at the aspiration. And this is what came out. And then I'm pulling it out. And let's look at the final arteriogram. This is how we started on the left, and this is how we finished on the right. Very good result. So thrombolytic and non-thrombolytic techniques are complementary, but there are complications. Don't forget that. I've seen all kinds of complications. Reality is there is a learning curve, and complications are overall quite low. I would say less than 3%, but you can see stroke, you can see death on the table, and you can see significant blood loss. Coronary sinus accidentally cannulated. We got a perforation, and when the patient received lytics, cardiac tamponade. Mechanical thrombectomy with the AngioVac device. We provoked tricuspid valve rupture and many other bad things. But we started 10 years ago or 12 years ago with a clinical failure rate of 16%. We're now down to less than 3%. These procedures, you cannot do them unless you have a team around you. So you need to create a PERT, a pulmonary embolism response team. Otherwise, it's really random. I'm sorry, I don't know why this happened. It's really random what kind of treatment you're going to get. Systemic lysis or thrombectomy or anticoagulation. If you don't have a PERT, it's really a chaos. Having a PERT, you know who to call, you have an algorithm, you have collaboration, you change the referral pattern, you develop and master interventional techniques. You have your follow-up clinic, you have your regular meetings, and you can develop research. We now have several meta-analyses indicating that having a PERT, you can increase access of patients to advanced therapies, decrease IVC filters without increasing bleed, and trends towards lower mortality. This is the PERT we created in Athens once I got here back in 2021. And then you might wonder, who is really the interventionalist? Whoever answers the call first. It can be the vascular surgeon, it can be the interventional cardiologist. Now, the majority of interventions are actually done by interventional cardiologists, then it's interventional radiologists, and about 20% is vascular surgery. So, catheter interventions are here to stay. Aspiration thrombectomy with novel technologies is a game changer. You can get faster clot removal. You can prevent RV failure. Maybe you can prevent RV pulmonary hypertension. These are not complication-free procedures. You need to carefully select patients in a high volume center with appropriate expertise within a PERT to get optimal outcomes. And I think I'm going to leave it somewhere here, and I will be happy to answer any questions.
So thank you, Marcus. One of my questions is, how often do you see these submassive or massive pulmonary emboli without a large iliofemoral DVT? Because there's a large clot burden that goes into these pulmonary arteries, and I personally have rarely seen it without a large thrombus burden in the lower extremities. So how often do you see this?
So to be honest, it's like my half and half. There are patients that you may not even find a DVT, maybe those with malignancies. You may see clot in the lung without seeing a DVT. The thing is, what I assume is just the entire piece of clot just went up to the lung. Or it's clot hidden in the pulmonary, in the iliac veins or the vena cava. But not all patients with submassive PE necessarily have that big of an amount of DVT. I would say half and half,
So let
roughly.
me ask you the other way. So in patients who have diagnosed iliofemoral DVTs on duplex scan, I've always been taught that about 15% of those have asymptomatic pulmonary emboli. So do you routinely do a chest CT scan if you have a large iliofemoral popliteal DVT looking for, because you mentioned in your presentation that a significant number, I think it was like 50% of these go on to have chronic pulmonary hypertension from asymptomatic disease.
That's a good question. I don't think there is a standard answer. We do routinely do it. But the reality, if the patient has no symptoms, chest pain, shortness of breath, how can this change your management? Maybe you can say, okay, I'm going to give anticoagulation for 6 months instead of 3 months. But if we have significant iliofemoral DVT and clot, we're going to do routinely. And most of the times, new machines are like very sensitive in capturing even small pieces of clot. So we're going to see some subsegmental or segmental thrombus there. And then the patient gets the diagnosis of PE, despite that the clot was very small. And then you have to go for a prolonged anticoagulation regimen.
And one final question. In these patients who have these large iliofemoral DVTs with pulmonary emboli, how often do you end up doing like cancer evaluations on them to see if there's some
All of
underlying
them.
malignancy?
All of them. All of them will get malignancy evaluation. I mean, chest scan, abdominal scan, and malignancy blood markers. We will do them routinely in all patients who present with an unprovoked iliofemoral DVT or pulmonary embolism. Don't you do
Okay.
it to everyone?
Depends on risk factors. If it's an elderly patient or if they have hypercoagulable disorders, I individualize it. I think if you do it on everybody, a significant number of them are going to end up being negative. That's actually kind of been my experience. But the large iliofemoral DVTs and Ps, I agree with you. That's a big red flag for me. I think most of those patients end up having an undiagnosed malignancy, the large iliofemoral PE patients.
Right. I mean, I would not do it for a tibial DVT that comes out of the blue, not even maybe for a femoral popliteal DVT, but for iliofemoral DVT with pulmonary embolism out of the blue, it's very suspicious.
Yeah. All right. Does anybody from the audience have any questions for Dr. Avgerinos?
No, great presentation, though. Thank you.
Have you
Very much.
started? Who does these interventions, Peter, at your center? Is it IR, cardiology, or you refer them
So
outside?
we're an outpatient center, so we would have to refer these patients. And most of these are done, like you said, in an inpatient center in the hospital for the large, because, for example, the Inari device is so expensive, you can't do it as an outpatient center. It has to be done in an inpatient center. So a lot
No,
of these one-shot, thrombectomies on the table, you can't do it in outpatient centers. It's all inpatient based.
Peter, a patient who is in good health to be in an outpatient center is probably not a candidate for a PE embolectomy. I mean, the patients who are candidates for epembolectomy should be in the ICU to start with. I cannot imagine a patient is that stable being on the floor and you have a good indication to do pulmonary embolectomy. This
I'm
is
thinking more of
pushing
the
the limits.
iliofemoral. I'm thinking more of the iliofemoral patient who has leg symptoms and no pulmonary symptoms. That's probably the more common thing that we see.
Agreed.
All right. So, Makis, thank you very much. Always a pleasure to see you. Hopefully, we'll come visit you in Greece soon.
Bye-bye.
Have a good weekend,
Thank you.
everyone.
Thank you.
Thank you.
Bye.